Welcome back to Wellness Wave Radio. Thanks for tuning in this morning to ride the wave with us. Each week our goal is to give you at least one suggestion that will make your life a little bit better. My name is Phil George. I'm a clinical biochemist, a certified personal trainer, and health coach. Please remember that everything we discussed on this show is for informational purposes only and should not be taken as medical advice. We have a great guest with us today. We have Dr. Eddy Arous.
Well, thank you very much, Phil.
And Dr. Arous is a vascular surgeon. So Dr. Arous, what the heck is a vascular surgeon?
A vascular surgeon is a surgeon who operates on blood vessels all over the body. So I take care of every blood vessel outside of the heart and outside of the skull. And for various problems, whether it's cholesterol buildup or blood clots.
We talked a little bit about the carotid arteries and those getting clogged up and kind of doing like a rotor-rooter type of thing and clearing them out. So that's one of the many things you do.
That's probably one of the more common surgeries we do.
And deep vein thrombosis, deep in the legs. That's stuff you've heard about. In fact, if you want to email me, philgeorge@charter.net, we did a whole hour-long radio show on that. So we're not going to do that now because we want to talk about something I didn't know about. I consider myself, pretty much up on a lot of these things. Is a great alternative to a knee replacement.
Correct. So it's a procedure called genicular artery embolization, which is very new. So I started doing this last year. It's very new across the U.S., and it's a non-surgical option for patients with significant knee osteoarthritis. And so it's really sort of taken off in patients in the U.S. It really sort of pioneered actually in Japan.
Right, and because I've looked into it, in terms of knee problems. And correct me if I'm wrong, but really, up to this point, really, your three options was one, a knee replacement, other one is something called platelet-rich plasma, and the other one was stem cells. Now, the stem cells and the platelet-rich plasma are not covered by insurance, so it's going to be over there. But this particular procedure would be covered by insurance. Is that correct?
Correct. Yes, it's been covered by insurance. So the procedure itself was first, I think. The process of genicular artery embolization. Embolization means to shut off the blood flow to, and the genicular arteries are the blood vessels that actually go to the knee joint. And so the way the procedure was first done was for patients who had a knee replacement and then had bleeding into the knee joint after the knee replacement. And the orthopedic surgeon, last thing they want to do is to go back in and remove the blood clot, and significantly because it has a major risk of causing an infection of the hardware they put into the knee. So the proceduralist would go on and embolize the arteries, basically shut off the bleeding blood vessels that were going to the knee to treat that area. And then ultimately, there was noted to have a pain improvement in patients who had this procedure before even having a knee replacement. And that's where it first got investigated, 6-8 years ago in Japan, then studies out of the UK as well, and now really has sort of entered into the US more so in 2023, 2024.
And one of the things that I found out, I had Dr. Arous on the show a few times, is I was under the impression, and I think this is true, but in terms of arthritis of the knee, we call it osteoarthritis, and it's just wearing away. It's kind of wearing away, and this happens. But what Dr. Arous educated me on was, in addition to that, it's also inflammation.
Correct.
So what's happening with this particular procedure, what you're doing is you're cutting back on the inflammation. By cutting back on the inflammation, you're having less wear and tear on the knee, right?
Correct. So the thought of osteoarthritis being a degenerative disease, of sort of losing the synovium or the lining of the knee joint, while that's true, what's actually happening at a cellular level is that the cells in that area are releasing cytokines, which are sort of a pro-inflammatory hormone, essentially, which then drives these molecules to the knee, and it causes the formation of new blood vessels called neovascularization, which is sort of not originally intended blood vessels to this area, and neo-innervation, so new nerve endings going to that area of the painful part of the knee. So the belief is that if you're able to embolize or shut off those creation of the new blood vessels, you can no longer deliver the pain sensors to the area. And that's why patients are reporting pain relief now up to 3 years after the procedure is done.
Right. The whole thing is what's happening because you're getting all this damage to the knee. The body's going in there and it's trying to put in more and more troops into that area to try to fix it. And you're getting more and more pain. And the more blood vessels you get, the more pain you get.
Correct.
So what you're doing basically, you're saying we're going to shut off all of the different cytokines going in there, and that will happen. So the main thing is you're not having the pain anymore. That's the whole thing. And this is an in-office procedure, right?
Correct. So the procedure itself takes about an hour to an hour and a half. I do it in the office. And so, you're with us probably about an hour or so before to get it set up, the procedure, and then you're home about an hour or so afterwards. So all day probably takes a half day. It's done with a needle that goes into either the groin or through the foot, and then we basically inject dye to find where these genicular arteries are. And through there we can deliver I think those little microscopic beads or little embolic agent devices to sort of shut off the blood flow to that area. And the pain relief usually starts about a week or two later. We'll be honest and say that usually sort of patients nurse a little bit more discomfort for the first couple of days after, and then they start to really see the improvement. And now the studies out of Japan and the UK have really sort of demonstrated 3 years of data of pain relief. Now it's a 4-year study, so I'm hopeful to give you the 4-year data next year.
But again, even if it didn't go the full 3 or 4 years, you're saying you can do a repeat procedure too,
You
right?
can absolutely do it again. And so it is fundamentally at a cellular level, I am not fixing the degenerative component of osteoarthritis. So that's addressed with a knee replacement. But there's certainly patients who either are not candidates for a knee replacement, either they're too sick, too old, too young, which we touched on as well. Patients maybe don't want to have a knee replacement in their 40s or 50s. They want to sort of wait to maybe have it done 10 years down the line. Or patients who just don't want to go through it. And then this is an option to get you pain relief, and if we have to do it again, we can do it again. That has not occurred yet in my practice, but it'll happen, I'm sure, eventually, or now I sort of see patients come back. Because at a cellular level, your bone, that synovium is still releasing the cytokines to try to create new blood vessels. So eventually, those blood vessels will be created in areas that I haven't treated, or they'll sort of overcome the blockages that I've created before.
So again, this is something I think because the knee replacement, it's funny because my wife was having some knee stuff going on, and she went to see an orthopedic surgeon. I remember him saying to her, he says, anybody that tells you a knee replacement is not a big deal is lying to you. He said it's a big deal. So it's a major surgery, and I've had a hip replacement done 20 plus years ago, and I've heard the knee replacement is even worse. So nothing I would look forward to. So hopefully I don't have to see you for a little while, but eventually, if I need, I would explore this before I would Let me ask you this: is there any possibility of doing this particular procedure along with platelet-rich plasma?
You could. I don't know if it's been studied, but having this procedure does not eliminate your option to having platelet-rich plasma, corticosteroid injection, or even a knee replacement. You can have a knee replacement a year later if you chose to. And so that's one of the referrals I've received for patients is someone who needs a knee replacement but doesn't really want to have it done for another year. They have a lot of busy traveling schedule. They want to be able to take the time off for physical therapy after the knee replacement. So they just want some pain relief for a period of time, 6 to 12 months. And yeah, absolutely, we can do the procedure then.
How long does the average knee replacement last? I know it depends on the patient, but ballpark?
So a little out of my social media, I'm guessing it's somewhere 10 to 15 years, something around that. So that's why I know that the orthopedist, I was surprised when I first met with a bunch of orthopedists, I was expecting to have a lot of 90-year-olds come to my office, but it was very much the opposite, where patients in their 40s and 50s where they're being sent over for early treatment of osteoarthritis.
And that's the whole point. You're buying a lot of time here. You're buying time with this. So if you're a younger person, people in sports, tearing ACLs and stuff like that, and it'll buy you that time because you don't want to have what's called a revision. So I know at the hip replacement revision is a nasty surgery. So you want to be able to. To bide your time with that.
Right. The worst thing is an infection of the knee prosthetic as well. And so that whole point of having a hematoma or bleeding afterwards is then you have to remove the implant or you have sort of a chronic infection. Albeit it's rare now, and knee replacements are definitely the gold standard treatment for knee osteoarthritis. It's just not everyone is a candidate for it. And so I've had patients that will either be getting steroid injections every 3 months, and those tend to sort of wear an effectiveness. So maybe someone will say, I used to get 3 months, now I get maybe 1 month of relief for it. Synvisc, which is hyaluronic acid, which is sort of a series of 3, think of it as a lubrication injection into the knee. You mentioned platelet-rich plasma, genicular nerve ablation, where you essentially burn the nerve going to there to, again, as a method to provide pain relief. They're all sort of multimodal approaches or non-surgical approaches for knee arthritis, and this is sort of The alternative method, where at a fundamental cellular level, I feel like it is the only one that really addresses the underlying inflammation in the knee joint. But yeah, there's more to come on this process of embolic therapy.
Yeah, we were talking about it because I have a fellow gym rat, and he's got. I was talking to Dr. Arous about this, about his shoulder, and you had mentioned on the show there was the other things they're looking at somewhere down the road, even prostate. You were saying.
So prostate's probably the more common one now than even genicular artery embolization. So the process of embolic therapy is sort of at the forefront of treatments for various medical diseases. So for prostate artery embolization, so we all know men that sort of get up multiple times at night to urinate, and it's just because of an enlarged prostate that's compressing on the urethra. So treatment strategies for that usually involve having to remove a section of the prostate with sort of major surgery or TURP. The alternative is to inject the same embolic agent to the prostate. So if you get the prostate to get smaller because it now has less blood supply, it releases some of the compression on the urethra, and it's going to alleviate the BPH, the prostate, in urinary retention. So that's sort of the genitourinary component of treatment for embolic therapy, but new things for musculoskeletal. Frozen shoulder is what is probably coming up next after the musculoskeletal, after genicular artery embolization. So patients with frozen shoulder, or adhesive capsulitis is the proper term. They're investigating for plantar fasciitis. They also are searching it for hemorrhoids, hemorrhoidal artery embolization. So there's a lot coming in the next 5 years about this. So genicular artery is brand new in the U.S., and there'll be others that I'm going to be doing soon, I'm sure.
And again, cutting off the blood supply to there is going to decrease the inflammation and like you're saying, the cytokine storm and everything else.
Right. I know we have some pictures that I could go through about like how it actually works.
Okay,
so,
Art, can you got some pictures?
So knee arthritis. So this is the phenomenon of knee arthritis is so common. I mean, 20 years ago, there was about 26.9, 27 million people affected, and certainly associated with age. So 30% of women, 10% of men, and the definitive treatment here is a total knee arthroplasty or total knee replacements, TKR. But there's many patients that are not surgical candidates or choose not to move forward. So the next slide, I think, should talk about how the process of genicular artery embolization occurs itself. So this is actually a picture of a knee joint. So the picture on the left under A is sort of a catheter that's into one of those genicular arteries. And all the gray haziness, particularly at the bottom segment of that picture, is all the neovascularization. Think of that as all inflammation into the knee joint. So the way we do the procedure is then we inject these beads that then disperse amongst all those branches to shut off the delivery of the cytokines or inflammatory molecules to that area. Then we take another picture, which is at B, and that's sort of the best results. We want to see all those inflammatory segments no longer visible. And that would be sort of a classic successful picture. And that's what we're looking for. And so now, fundamentally, on the next 3-4 years, is that patient going to form new blood vessels? Ultimately, yes, they will, because the process of the arthritis is still there. But there's nothing preventing you from doing that again. So the term of genicular artery embolization is a bit of a misnomer, because I'm not actually shutting off the genicular arteries. I'm shutting off the capillaries, which are sort of the smallest branches of these blood vessels feeding the knee joint themselves.
I'm thinking, just to really simplify it for the audience, it's kind of like if you have inflammation and you take like an aspirin or something like that. So the inflammation is there, but what's happening in these anti-inflammatory things, you're kind of shutting down the inflammation. So you're kind of doing this more mechanically than you are by using a drug. So I think the principle's the same.
Correct.
You're really shutting down. And again, if you messed up your elbow, you banged your elbow or something like that, it's still going to be damaged, but you don't want the pain. So by you taking the anti-inflammatory, basically you're cutting down on the pain, but the damage is still there. So what you're saying.
Absolutely. So NSAIDs, non-steroidal anti-inflammatories, ibuprofen, Motrin, whatever, it is all affecting your ability biologically to generate those pain molecules. What this process is essentially blocking the delivery of the pain molecules to the area of your injury. And so, yes, it can hopefully reduce the chronic pain requirements, chronic, NSAID, obviously has risk of ulcers, opioid dependence, all that is fundamentally benefits of having this procedure done to limit the amount of pain the patients are enduring.
Right, and the other big thing is this is, as opposed to, you don't want to be taking NSAIDs nonstop, like to match all the side effects that you can have with that, or even corticosteroids.
Right.
And there's a lot of side effects with that. So a person is in chronic pain, if they're taking corticosteroids or they're taking NSAIDs and things like that, This is, again, mechanical, but I wanted to maybe get the audience to know this is kind of the same principle. It's kind of anti-inflammatory, but using a mechanical as opposed to a chemical.
Right. So this is entirely done in an office setting. So this is not done in the hospital. You don't need to go to the hospital. So typically you'd see us for a consultation. You have to fill out like a pain questionnaire about to quantify your severity of the knee arthritis. And then we figure out whether you're a candidate or not. And we had then, during the procedure, the analogy I tend to tell people, it's like, it's like going to the dentist. Your dentist tells you that, oh yeah, you have a cavity, we should get this done. You come in scheduled for a couple weeks later, and we do the procedure, and you're out the door. So I need to get to the arteries within the knee joint themselves, which can be done through two main ways, either by putting a needle into the artery in the groin, or putting a needle into the artery in the foot on the same side of your leg as the knee. And then I inject the dye. I'm looking to see that big blush, that hypervascularity, and then target those blood vessels specifically to that area. And then that's really the hard part of the procedure is these are not big blood vessels, so I need to navigate a catheter and a wire into those small branches to then inject it and treat. And then once it's finished, everything comes out. We put a little Band-Aid in the groin or in the foot, and you lay flat for half an hour, have some crackers, and then you're out the door.
Right, and what's the average time for a procedure?
Duration, it's about an hour to an hour and a half, total duration.
Okay, so that's short. Other thing I like about it is, as you get older, you got to be careful with anesthesia because it can mess up your brain.
So this is entirely done. So we usually give patients a Valium and a Benadryl, so they're a little more comfortable. Some people will take a nap, some are awake, and then you'll have an IV during the procedure. But otherwise, during the procedure itself, it's just local anesthesia. So there's no, you might have oxygen, sort of oxygen mask, but you are not getting any additional anesthetic. If you're feeling a little uncomfortable, you have an IV in, so we can give you some short-term pain medication or anxiety medication as needed. But the majority of patients, I'd say 80 to 85% of patients, do not need any IV medication. And then they're out the door and home. You obviously need a driver to take you to and from the procedure, but you're not driving home after taking Valium. But it's very straightforward. And patients are usually, I limit them in terms of some heavy lifting for about 2 days. And then they're back to the normal activities.
The other thing was interesting we did on the radio show. Feel free to email me, philgeorge@charter.net. We went through the whole thing about different types of, arteries and stuff like that. But it was funny because I was mentioning to Dr. Arous. I listened on Sirius. They have something called Dr. Radio. Not that I agree with everything they say, but I like listening to just have different points of view. And I was listening to this surgery show, and it reminded me of you because during the show, we're going to talk who shouldn't have this done in a second.
Right.
But one of the things that he said was, the surgeon says, well, the sign of a good surgeon is knowing when to operate. The sign of a great surgeon is knowing when not to operate. Right. And that's basically what you said. So who would not be a good candidate for this? So
the main risk of the procedure is something called non-target embolization, which implies that some of these beads are going to the area or to the artery they were not intended to. So fundamentally, that implies someone who's already has blockages in the blood vessels to the leg. That's the diagnosis called peripheral artery disease, which is something that you would see a vascular surgeon for anyway. Say the majority of my practice up until last year were patients with PAD, peripheral artery disease. So that's a test that I need to do, or during an assessment I need to do during that original consultation to see, does this person have some element of cholesterol buildup in the blood vessels to the leg? Because if so, I would argue that the blood flow to that person's foot is compromised at baseline. So the last thing I'd want to do is now shut off or potentially risk shutting off some of those additional blood vessels going down to the foot, which can really jeopardize their limb. And that, my job, the other time when I'm not doing knee arthritis, is preserving patients' legs. Certainly have patients that ultimately end up needing amputation, which is what we're trying to avoid. So the last thing I want to do is do a genicular artery embolization and then risk someone who maybe has some subclinical peripheral artery disease. So that's all testing that I do in the office on ultrasound, which we have a full vascular lab, and we do it that way. So it's the one thing you need to make sure you do not have. But the main indication mentioned is for knee arthritis. This is not a treatment for rheumatoid arthritis, knee infections, all those other things that I need to sort of assess in the original consultation.
Right, another thing was interesting we were talking about too on the show is we were talking before about calcium artery scores and ultrasound. You look at the carotid to see kind of like the analogy I like is if you're in your kitchen and you're turning the faucet and eventually it's getting smaller and smaller and smaller, and you don't really know how much calcification you have in here. And Dr. Roos said they don't do a screening test for this. So in other words, you can't go to your doctor and say, well, what kind of a calcification do I have? Normally you're not going to get paid for. But I see something we could do here. So if you come in basically for the knee, and Dr. Roos, you see where I'm going with this?
I get it.
And Dr. Roos says, well, you know what? You got calcification here.
Right.
Well, you don't have to pay for that because basically he's already done it. So you're going to get kind of a twofer here. You'll be able to figure out what's going on with the knee, but you're also going to be able to find out if, he can say, well, great, your arteries are nice and clean. We're good to go. Or he could say, guess what? We got some calcification here. Maybe should do something about that. So either way, you're going to get information that you didn't have before.
Right. So calcification is sort of a marker of cholesterol buildup. And so atherosclerosis or cholesterol buildup within the arteries leads to calcium deposition, which really doesn't show up clinically unless if that calcium now narrows the lumen or the pipe that the blood vessels are that the blood is traveling through. Sometimes if someone has really severe calcification, you will see calcification in the blood vessels on an x-ray. So maybe someone out there has had a knee x-ray and they see the report that says vascular calcifications present. That's a sign that you have some underlying cholesterol buildup. And if so, that's something you should be evaluated for and make sure you're on the proper medications. I would not recommend likely this procedure for that treatment, but I will tell you that if an orthopedic surgeon sees that you have vascular calcifications in the blood vessel there, they're going to be very hesitant to offer you a knee replacement for the same reason, is that they'll be concerned about the ability for you to heal that area if they do surgery.
Right. I think the other big thing we talked to in terms of the calcification. This is found interesting. We talked about this on the show on the radio show. Is if you see an ophthalmologist, we talked about this. You get very tiny capillaries in your eyes, and when I go in once a year to my eyes checked, they take a picture, and I always ask the ophthalmologist, how do my blood vessels look? Because that's what they call the canary in the coal mine. So if these start closing up over here, you had a word for that.
So it's a term is called Hollenhorst plaques, which implies that if they'll see cholesterol in the retina, or sort of the branches of the retinal artery that go to the eye, that essentially blocks the blood flow to that segment of the eye. So you will get blindness or a black spot in that area. So the concern is, where do these cholesterol plaques come from? They don't usually arise directly within the retinal artery or the ophthalmic artery. They came from somewhere more proximal, so somewhere between the heart and the eye. And the most common location is the carotid artery, so the blood vessel on the neck. So if you had that, typically your ophthalmologist is going to recommend you get a relatively urgent, either a CAT scan or an ultrasound. Ultrasound being the easiest, cheapest, fastest method. So that's typically what we do, and so we do those tests very often in the office. The other thing that your primary care physician might say is sometimes listen to your neck and hear a carotid bruit. Bruit just implies turbulent blood flow, and if that's the case, that's most definitely an indication for a carotid ultrasound as well. Now, we do not, for the whole surgery versus no surgery, we do not operate in every element of carotid stenosis. It depends on how narrowed it is and whether or not the patient has symptoms associated with it. But if the doctor or your PCP hears a carotid bruit, only about 25% of the time does that actually mean that you have a significant carotid narrowing, meaning over 60%. But I'll tell you, 89% of the time it implies that you have some cholesterol buildup and that there's some carotid plaque there. So absolutely, if you have a carotid bruit, you should have an ultrasound. And even if you don't have a significant narrowing, you're just sort of in that mild range, those are all things to identify early so you can make sure you're on the right medications to reduce your risk of having a stroke. And then we tend to do surveillance, meaning we'll monitor the carotid narrowing annually or so to make sure that you're not progressing to someone that has a much higher risk of stroke.
Right. That thing I tell my clients is basically it's cheap, right? It's a poor man's calcium artery score. The doctors are anyway. Listen to your heart. Just ask them. Go up another couple of inches and just say, what do you think? You could pick it up before you have a stroke. You have a stroke or heart attack. Other thing we discussed in the show is the number one fear that older people have is not cancer or heart attack. It's a stroke. That goes to the brain and they become basically a vegetable. So these are things, and these pathologies don't happen overnight. I mean, this stuff is building up. Your body's telling you stuff, so it's a good idea. You're going in for your annual checkup anyway. Have them listen. There's no downside to that.
Right. So you asked me at the beginning what a vascular surgeon is, and previously I said, well, why did I choose vascular surgery or something else? A vascular surgeon is someone that, I'm married to my patients for life. typically. I'm not a general surgeon who I take your gallbladder and send you on your way. Typically, someone with vascular disease will have vascular disease for their lifetime. And so we are managing the disease. So, you know, if someone has a significant carotid stenosis, carotid narrowing, and I have to do surgery, great. But I need to monitor that side to make sure the narrowing hasn't recurred. Even more so, they have another side I need to make sure it doesn't progress. So I need to be monitoring these patients forever. So and fundamentally, someone has narrows in the carotid artery, so they have blockages in the heart arteries, blockages in the leg arteries, all these things which we are better to sort of discuss and manage long term. That's what's going to provide the best longevity and avoid, hopefully, future surgeries.
In fact, that's how we met. We have a mutual friend who shall go unnamed because I know he watches this. And he had a DVT, a deep vein thrombosis. Right. And then he says, you just have to have Dr. Arous on the show. That's kind of how we met. But I know he just saw you a little while ago that we talked about that. So it's ongoing. Because again, you can correct me if I'm wrong in this. I heard actually from Dr. Radio, it says usually the number one sign of a heart attack is death. It happens really quick. So, but in the meantime, your heart didn't all of a sudden stop. Correct. It was telling you for a while there's something going on here. So that's why you kind of want to keep an eye on it, because again, most people's number one fear again is stroke. So right. That's what you want to prevent. So if Dr. Arous, if you got something going on here, and then what are the other? You have obviously there's a lot of medications you can give.
Right. So for carotid disease or peripheral disease, so typically low-dose aspirin, so baby aspirin, 81 milligrams, typically I know we talk about statins, and there's obviously new medications for cholesterol management, which are less commonplace. They're very expensive currently, but I expect them to be more available in the next 5-7 years. And then for certain areas, we actually do low-dose blood thinners for peripheral artery disease. You've probably seen the commercials for Xarelto, called rivaroxaban. So there's a lot of treatment strategies, but even more so, even just discussion about exercise programs, ambulating. So typically if you have peripheral disease, we'd recommend a structured program. You walk 30 minutes a day, 5 days a week, which is covered by Medicare. There's a whole global PAD hotline number that we can connect you with. And then, medical management stuff, things that most patients have heard, smoking cessation. One of the main risk factors for peripheral disease, cholesterol and plaque buildup, is smoking. And we're happy to have that discussion and assist with patients interested in stopping smoking. And then, of course, high blood pressure plays a role, high cholesterol, age, diabetes management. So it's really important to make sure that we have you properly aligned with the necessary docs and meds to manage your multiple conditions.
But I think also we both agree on is lifestyle changes. And one of the things you talked about on the show, which I really liked, is in terms of the difference between the arteries and the veins. Right. And the only way that the blood gets back up to your heart is basically with the muscles in your leg. You want to talk a little bit about that?
Yeah, so your heart pumps the blood. So people sometimes get confused about circulation for arteries and veins. So everything that gets pumped out of your heart, for your toes, your fingers, those are through the arteries. Veins bring the blood back towards your heart. But there's no heart on the vein side. So you use your calf muscles. So your veins have valves, section of one-way valves to bring the blood up towards your torso. And so when you walk, imagine you step on the gas pedal, you squeeze your calf muscles, that squeezes the veins as well and propels the blood upwards. Now it doesn't get all the way back up to your torso with one squeeze, but so then those valves close until you squeeze again. With someone who have DVTs or varicose veins or other conditions that we treat, fundamentally they either cause, so DVTs can disrupt the valves and can increase your risk of having valve dysfunction, or if you have varicose veins, you likely already have valve problems. And it impedes the return of the blood back up towards your heart. So then patients can present with chronic swelling, chronic achiness, throbbiness, and then long-term risks of chronic ulcers, which is sort of breakdown of the skin. The most common cause of an ulcer in someone's leg that patients go to the wound center for is actually a venous ulcer, meaning a vein-related ulcer. And so there's multiple treatments that we can do now in terms of managing the veins, whether that's closing the veins or stenting the veins to improve the return of blood back up towards your heart and offload the amount of swelling in your leg.
Now, that must be related to diabetes too, I'm guessing, right?
So diabetes and vein disease, not actually entirely, but it certainly confounds things. Because you can have a primarily diabetic ulcer as well. Or you can have both. You can have a diabetic ulcer and a venous ulcer together. But fundamentally, diabetics can get arterial blockages, but not typically on the vein side. It's very different.
So you're saying that, so the varicose veins is kind of a sign you've already got problems?
If you have varicose veins, you already likely have dysfunctional valves within the legs in your within the veins in your legs, and so that's what leads to sort of the bulging veins. So instead of the blood properly draining back up towards your abdomen, towards your heart, whenever your leg is down and not moving, those valves now are no longer closing. So the blood returns back down towards the lower part of the leg, and now those veins are dilated. So when you have varicose veins, that implies that now those veins are holding more blood than they're intended, so they become more bulgy, or they'll protrude more towards the skin. So fundamentally, people always ask, why can't I just remove the veins? Like, yeah, and we do that, but unless you've addressed the underlying valve problem, you're not really treating the underlying issue. So you have to turn off or shut off the vein that has a dysfunctional valves. Otherwise, the analogy I give is, if you have varicose veins, we just take the veins out. It's like your house is flooded and you're just throwing buckets of water outside. You have to turn off the faucet first. So I would, again, in the office, we turn off the faucet by shutting down those veins. And that's all done similarly with just catheters and wires and under local anesthesia. And so these are procedures I used to do in the hospital 5+ years ago, but now there's really no need to have any of these done in the hospital. They can all be done in the office. Again, those take about 30 minutes. That's
something else. I didn't know that. So I can, again, going back to to my saying, the canary in the coal mine. So if you're basically, if you're having varicose veins, I think you should see Dr. Arous, because it's telling you there's something going on. So don't wait until you get ulcers, ulcers in your legs and stuff like that. It gets worse. You want to fix it.
Right. So predisposes you to certain types of blood clots as well, and then ultimately venous ulcers, which is sort of what people are really trying to avoid long term. The amount of expense and morbidity from chronic venous ulcers, these ulcers take years to heal. And the amount of medical supplies and trips to the wounds care centers, it's challenging. And so it's certainly patients, better to be proactive. And the whole point of all these patient education series that you're doing is really for prevention. And so our goal is to prevent the population from getting to these significant issues of chronic venous ulcers. So better to come get a diagnosed early and figure out the treatment strategy. It's certainly much easier on my end to fix these patients early on in the process.
Right, it's similar to type 2 diabetes, and it's really, like I say, it's really insulin resistance. Is you want to catch it early, because the more you go on with diabetes, the worse it's going to, the harder it is to try to get under control. So again, like we talked about, you want to find out kind of ahead of time, because the longer it goes, I'm guessing the more damage you're doing, right?
You typically, now you have a more overloaded vein system specifically. So until you do it, you're just going to cause more issues with chronic leg swelling, and now again increased vein capacity within the leg, which is not the goal. That was not the intention. So, and people always ask, what are risk factors for vein disease? Why do I get it? And typically, it is more common in women, more common related to pregnancies, hormonal changes associated with pregnancies. But certainly people always talk about, oh, I worked as a waiter for years on my feet, and that certainly contributes. And we talk about compression stocking use, and the way the compression stockings work is that they inevitably are replacing the valves within the legs. But they're not fun to wear. I don't envy people that have to wear them all the time. But we have to sort of at least attempt a conservative therapy, and most insurance companies require you to at least try the 6 to 12 week course of compression stockings before. But that's all patient education component that we do when we first see in the office. So again, we're happy to see patients for vein disease, carotid disease, knee arthritis. We manage it all.
Okay, so coming up to the end of the show, so how do they reach you?
So I have two offices. The main office is in Worcester at 21 Eastern Avenue in Worcester. We also have an office in Sturbridge. That's 214 Charlton Road. The phone number is 508-556-0223, and we're at the Vascular Care Group. Happy to see you.
And just email me, philgeorge@charter.net. I'll shoot it over to Dr. Arous. So Dr. Arous, thanks so much for coming on.
Thank you very much.
Thanks for joining us, guys. We'll see you next week. One of the most common questions I'm asked as a biochemist and health coach is, what are the best supplements to take? Choosing supplements is a tricky business. Many companies have poor quality control and questionable ingredients. In the past, I had to send clients to several different websites. I am now able to offer one-stop shopping for all the quality brands I recommend, with no shipping cost and a lower price in most cases. Just email me, philgeorge@charter.net, for a free consult.